would like to welcome you to today's education activity entitled Degendering Symptom Assessment to Appropriately Evaluate for Malignancies. Today's program is supported by an educational grant from Merck Sharp and Domi Corporation. And today's activity is brought to you by CME Outfitters, an award-winning jointly accredited provider of continuing education for clinicians worldwide. Again, I am Dr. Don Dizon. I'm a professor of medicine and professor of surgery at Brown University, director of the pelvic malignancies program and hematology oncology outpatient clinics at Lifespan Cancer Institute, and the head of community outreach and engagement at Legoretta Cancer Institute at Brown University. And finally, I am director of medical oncology and founder of the Oncology Sexual Health First Responders Clinic in Rhode Island Hospital in Providence. Now let me introduce our faculty. I am privileged to be joined today by Dr. Ash Alpert, an AHRQ T32 postdoctoral fellow in health services research, based at the Center for Gerontology and Healthcare Research, Department of Health Services, Policy and Practice at Brown University School of Public Health in Providence, Rhode Island. Welcome, Dr. Alpert.
Thank you. Glad to be here.
Me too. Let's start by reviewing our learning objective for today's session. After participation in today's activity, clinicians should be better able to apply efficacious and non-gendered approaches to symptom management. Before we watch our 3 patient interaction videos, let's take a minute to review some of the concepts and terms that we will use in today's discussion so that we were all on the same page. What's important to understand is that sex assigned at birth and gender are often mistakenly used interchangeably, and it's not appropriate at all to assume anatomy based on gender. It's still quite an important concept because, as we know, that sexuality and gender are often conflated inappropriately.
Yeah, in some ways, like there's multiple different concepts that are conflated. So like if we know someone's sex assigned at birth, we think we know their gender, we think we know their chromosomes, their hormonal milieu, and then we also often think that we know who that person will be attracted to, how they'll identify in terms of their sexual orientation, what kind of sexual behavior they're going to engage in. Yeah. When really we just know one thing when we know one thing. So I think there's a lot to disentangle and unpack.
I think that's a really important point. Moving forward, the NIH and ASCO have recently begun to recognize the unmet healthcare needs of the SGM, or sexual and gender minoritized population. Currently, the data we have in this group is limited, but we know people in this group have poorer outcomes than the cis-normative populations. And Dr. Alpert, is there anything else you want to add on that as well to give it more context?
Well, I mean, I think that it's really what's really exciting about, being alive and being a scholar and researcher and clinician today is that for the first time in my lifetime, large oncology organizations across the US are starting to recognize the ways that we've often described bodies, identities, and experiences may leave out a lot of us. So I'm really happy to be able to be working right now and working with you on really changing the landscape for sexual and gender minority people with cancer. It's a really exciting time.
It's incredible to think that it's just starting now, that this movement, which if you just compare it to, say, when gay marriage became legal, has come before the collection of SGM people identities in health records. It's just incredible. And I think what it reflects are the many barriers that SGM people face to their receiving high quality health care. And that includes cancer screenings. These range from the personal to the systemic, and it ranges from outright discrimination and hostility to activities of implicit bias, where unintentionally at its face, some of the most disheartening and offensive comments can be made. For example, when it comes to cancer screening for cervical and breast cancer among SGM patients, there's a substantial lack of knowledge around the stress that goes with screening and about screening themselves. And if you look at the data that's been reported, we now are understanding, and it's been seen across multiple data sets, that sexual and gender minorities do have lower rates of screening. And that includes with mammography, and it includes with pap smears for cervical cancer screening. So Dr. Albert, when we think about the factors that clinicians have control over, we can think about both conscious and unconscious biases. Sometimes the unconscious bias is called implicit biases. The conscious biases are the things we recognize, but it's the unconscious or implicit biases that are harder to identify. What do you see are some of the unconscious things we do that discourage SGM patients from receiving the care they need?
Well, I think even to, move out a little bit from the individual clinician, we're all trained to think about bodies in a certain way, and to think that when we see a person, we'll know what sort of anatomy they likely have and what kind of cancer screening they may need. And we're not taught to think about these things more critically. So when a person walks into a room, we're often thinking that we already know like what pronouns they might use, what body parts they might have, and what healthcare needs they might have as well. So really trying to unpack that and do things differently. First, by asking patients how they'd like to be referred to, and also by potentially doing an anatomy inventory, preferably in written form, so that we know what their cancer screening needs might be. And then similarly, when someone comes in with symptoms, not assuming that we know what anatomy they have. So in the scenario that we will watch, what happened in the first two versions was that the primary care provider assumed that they knew that the person's anatomy by looking at them, and also assumed that they knew their pronouns and how they would describe their gender. And then in the second scenario, when the primary care provider saw in the chart that the patient was transgender, that changed the care, but not in a positive way.
Mm-hmm. And if you think even beyond that, there is a term that I've recently come to know, and it's this whole notion of being stealth, that one is not going to be asked about their pronouns or their gender or their orientation unless it's obvious to the provider. So if you're not, quote, obviously gay, if you're not obviously trans, they're going to assume a very heteronormative persona applies to you. And, and I've heard, and I would love your comments on this, for some trans people, the experience of developing into their own fully formed selves and really seeing their selves recognized is a road that's paved in trauma, and any aspects that could threaten who they are now or bring up those experiences can be considered triggering. And many of these triggering events are occurring in the context of healthcare. So it's almost a relief, almost. I'm not sure if I'm using the right word, when someone who is trans can pass for cis, because it means they won't have to deal with that. But I think on the other end of it, it just goes to show that the biases we have, they actually stand in the way of a fully formed doctor-patient relationship.
Yeah, I would agree that sometimes the ways that we that our biases become clear to patients do get in the way of rapport, and that can really, potentially damage a relationship in the long term if we can't figure out ways to repair.
Yeah.
And in terms of what you were mentioning earlier, yeah, we know that a large number of trans people have negative experiences with clinicians, and that because of those experiences, many people don't seek care even when it's needed.
Mm-hmm. Mm-hmm.
And I think that many of us who are LGBT, even those of us who are clinicians, experience many microaggressions and traumatic events in the setting of clinical care that make it very difficult to continue to access care even when we need it, even if it's something like cancer screening.
Yeah, and I think it goes back to the point that I'm hoping we will make in this activity, that we should not assume who the person is we're going to see, and that it's up to us to be curious enough to ask them to tell us who they are using their words and their definitions. Because, you know, when it comes to someone's self, the only one person who knows who that person is the person sitting in front of you. No one else really knows that. But Dr. Albert, just to move on just a bit, can you talk about also the systemic ways that these hostilities might manifest, sort of environmental cues of unfriendliness, for example?
Yeah, so, you know, beyond just the patient and clinician sitting in a room together, there's the institution that they're sitting in, and that institution likely has non-discrimination policies that may or may not apply to transgender people, along with sexual minority people. The other thing that people might notice when they walk into a clinic is, what's the situation with the bathrooms? Will I be able to access a bathroom that I will feel comfortable in and not get thrown out of? And then in addition, I think people really pay attention to what's on an intake form. So if the intake form makes clear that trans people are invisible in the minds of the clinicians, it's going to be much harder to be out to the clinician. So for example, at an institution that I used to work at, the intake form said, for women, when was your last period? And of course, like if I'm a man and I'm menstruating, it might be very difficult for me to figure out what to write on that form.
Mm-hmm.
And similarly, in our research, we've heard from transgender women who present to an appointment and are gendered correctly, but then someone will ask them, when was your last period and might you be pregnant? And at that point, it's very hard to figure out, should I lie?
Mm-hmm.
Or should I come out to this person who clearly has not thought about that I might exist as a trans person? And then beyond the walls of the clinic, you know, there are laws that that vary by state in regard to what services are covered under Medicaid, for example. So in a state where gender-related healthcare services are covered, a person might have a very different feeling walking into a clinician's office than in a state in which that's different.
Those are excellent points. Thank you very much. Do you want to go ahead with introducing the scenarios?
Oh, sure, I'd love to. So in our scenarios, there's a patient named Dominic who uses they, them pronouns, who presents to their PCP because they're having back pain and cramping that's been going on for a number of months. So there's 3 scenarios that we present. In the first one, the primary care physician assumes that the patient is a cisgender man, so asks about symptoms that the primary care physician thinks would be related, and therefore misses what's going on with the patient. In the second scenario, the primary care physician also assumes the patient is a cisgender man, but then goes ahead and looks at the patient's chart and realizes that the patient is transgender, and then begins to ask a number of inappropriate, or at least questions that don't land well for the patient.
Mm-hmm.
And then goes on to assume that the patient is pregnant and refers them to OBGYN. And then you see the patient try to make this appointment and have great difficulty making it because their name is Dominic. Mm-hmm. And the person that they speak to on the phone doesn't believe that they need to make an appointment with OBGYN. In the final scenario, the physician introduces themselves with their name and pronouns and asks the patient to do the same. The physician has already obtained an intake form that has an anatomy inventory, so knows the anatomy of the person in front of them, does a thorough assessment of their symptoms, and finds out that the patient, in addition to having back pain and cramping, has also had a 15-pound weight loss and becomes concerned. And in the end, refers the patient for an ultrasound.
Hi, welcome, Mr. Bell. What brings you in today? Hey, I'm having a lot of cramping and abdominal pain
Okay. How long has this been going on for?
for months.
Okay, I see. Where do you feel the pain exactly?
The lower left side
Okay. When was your last bowel movement?
yesterday.
Are you having any burning with urination?
No,
Any change in your ability to urinate?
no,
Any incomplete emptying of your bladder?
no,
And are you currently having sex?
I am.
Okay, well, I'd like to test you for a urinary tract infection and for some sexually transmitted infections as well.
All right, let's do it.
All right, Mr. Bell, everything's negative. And since you're a man, I'm assuming that the cramping is unrelated to the back pain, maybe indigestion, and that maybe your back pain is something musculoskeletal. So I'll give you some ibuprofen and then I'll see you again in a month.
Okay.
So I think if we look at the first encounter, I think it's really striking. It's a striking example to me of this whole phenomenon of being stealth. Someone can walk in, gender is automatically assigned based on appearance. And he's referred to as Mr. Bell, and then a line of questioning that subsequently follows, which is essentially almost gendered. Wouldn't you think so? Wouldn't you say?
Yeah, you know, it's interesting that you've introduced this word stealth. So the word stealth in the trans community refers to somebody who lives their life without people knowing that they're transgender. And in this scenario, I actually do not think the person is stealth. The person is very happy to provide their pronouns and has provided their anatomy inventory on their intake form. But unfortunately, because of the assumptions of the primary care provider in the first scenario and the second scenario, is not provided with an opportunity to give information about themselves, including their pronouns, but also their anatomy. And so the physician then ends up making incorrect assumptions that lead the patient to be sent away without any follow-up for very concerning symptoms.
You know, I think, Dr. Albert, some could envision that, you know, because again, putting in the context of where we want patient engagement to come from, we often will talk of self-advocacy, of standing up for what you need from your healthcare providers. I don't think it would be that much of a stretch for people listening to think, if they are trans, they should tell me and not wait for me to ask. What do you say about that?
Well, I think the difficulty with that, I mean, I think there are a number of difficulties with that. And one of them is that, you know, there's really no reason that any of us should have to live in a world where our identities are assumed to be other and not the default.
Yeah.
And so I think it really behooves us as physicians to think about bodies and experiences in a broader way.
Yeah.
And secondly, I guess what I would say is that, you know, from our research and also from the literature, we know that transgender people often have negative experiences with clinicians, that they experience things like harassment and even assaults in the context of physician visits. And so if somebody is assuming that someone is not trans and makes that clear in their language, it may be very difficult or possibly even not strategic to come out to them, because coming out to them may cause the patient to not be safe. And so in some ways, patients are navigating very difficult choices, because on the one hand, as in these scenarios, physicians may not have all the information they need for clinical problem solving if the patient doesn't come out or doesn't talk about their things that are relevant for the clinical visit. And on the other hand, if patients come out, then they're potentially facing things like harassment and even worse. So I think it's a very difficult situation for patients.
Yeah, and I think all of this comes down to the concept that this all could have been avoided. As this patient has alluded to, it's important not only to understand that patient by talking to them, but it's really important that we are the ones to guide the queries. And this includes getting into sexual orientation and gender identity, or SOGI questions. And I think, as you just, beautifully explained, it's like this whole notion that the patient before you reflects their orientation, reflects their gender expression, reflects everything about them is an incorrect thing. And you don't have to look gay, lesbian, or trans to prompt those questions. I think that's such an important point. But Dr. Albert, you want to take us into the second encounter?
Sure. So in the second encounter, I think I may have mentioned this earlier. What happens is the patient walks in, the physician assumes that they are a cisgender man, and then the physician looks at the chart and finds out that the patient is transgender, and then proceeds to ask a number of questions about that.
Hi, welcome, Mr. Bell. What brings you in today?
Hey there. I'm having a lot of lower back pain and some abdominal cramping
How long has this been going on for?
for months.
Okay, let me take a look in your chart quickly. Oh, I'm sorry. What is your sex?
Legally or assigned at birth?
Your biological sex.
Female.
When was your last period?
I don't get periods,
We should do a pregnancy test.
but I'm not pregnant.
Are you currently sexually active with a man?
I am, yeah.
Okay, we should do a pregnancy test.
Okay.
So your pregnancy test came back slightly positive. Let's put you on a prenatal vitamin and send you to obstetrics and gynecology. I'm glad you came in today.
Yeah, there are a bunch of issues that this does bring up, but I can also see the dilemma that we are actually trying to address in some of our outside work, which is preparing the clinical team to sensitively and equipped with knowledge how to address these questions that are so inherent to one's identity and one's idea of personhood. I think there are challenges to so much of this, and I think one of the things that I hear about from clinicians is this will come up rarely in their clinics, and it seems strange to devote this much time to that one-off patient. And I think, as we've discussed in the past, the assumptions even in a statement like that are pretty incredible. That if you think it's rare, and what's the harm in hurting one person since 99 people are going to feel just fine about it, really goes against all of these concepts that we have and are working towards, equality and diversity and inclusion. All of these big concepts in healthcare today will never be realized unless we address SGM people as well.
Mhm. Yeah, I mean, the reality is that most oncologists are seeing trans people, whether they know it or not.
Mm-hmm.
And I think the whether they know it or not is really important to consider, because I think that the more you think you're never going to see lesbian, gay, bisexual, transgender, queer, and other non-cisgender and non-heterosexual patients, the less likely it is that your patients are going to be out to you, and the less likely it is that you're going to know that you're seeing sexual and gender minority people, whether or not you actually are.
Right. Dr. Albert, I think one of the other things this encounter brings up is what might have tripped up the physician, him or herself at that time, or themselves even, is the way you ask the questions around sexual orientation and gender identity. So much of our forms aren't asking assigned at birth versus what is your current gender. So it literally says, what is your gender? Male, female, other, or write in. But you actually need to contextualize that, because, as you so clearly stated, when you ask someone about their sex, which you should probably say, what is your gender? That can have very different connotations. Do you want to expand on that a little bit?
Yeah, so I mean, what we know is that the word gender means a lot of different things to a lot of different people. So when physicians ask about gender, what they actually might mean is sex assigned at birth, or
Mhm.
they might be trying to ask about a whole variety of things: sex assigned at birth, current anatomy, hormonal milieu,
Mhm.
but not really have the words to ask more nuanced questions.
Mhm.
Whereas gender, usually what it actually is usually about is someone's sense of themselves as a man, woman, non-binary person, or something else.
Mhm.
But since many people are using that word in a different way, it becomes almost impossible to know what someone means when they ask the question without more context.
I think that's brilliantly stated. Shall we go into the third encounter?
Oh, sure. So in the third encounter, the patient walks in, and the first thing that happens is the physician says hi, provides their name, and tells the patient their pronouns, which happen to be they, them, and asks for the patient's pronouns. So the patient then states their name, which is Dominic, and their pronouns, which are also they, them. And then they go on to talk about symptoms.
Hi there, I'm Dr. Alpert. My pronouns are they, them. What is your name and what are your pronouns?
Hey there, my name's Dominic Bell, and they, them pronouns honor me.
Okay, great to meet you. What brings you in today?
I'm having a lot of cramping and lower back pain
How long has this been going on for?
for months.
I see. Did you have an injury that you remember?
I did not.
Where in your back does it hurt exactly?
The lower left side,
And what does the pain feel like?
it's very sharp.
Okay, has it been getting worse, better, staying the same?
It stays about the same.
Okay. Does anything make it better or worse?
I've been using heating pads, but I don't know if it makes it any better.
Okay. Does the pain radiate anywhere else in your body or does it move around? Do you feel it anywhere else?
No.
Have you had any changes in your weight?
Yeah, I lost about 15 pounds.
Okay, were you trying to lose weight?
I was not, no.
And how long has it been since you lost that weight, or over how long of a period did you lose 15 pounds?
Roughly 2 months.
Okay. Any night sweats?
No,
Any fevers?
no.
Any new lumps or bumps anywhere?
Yeah, the left side of my groin.
Huh. And when did you first notice that?
A couple of months before the pain started.
Okay. And you mentioned that you've been having some abdominal pain?
Yeah, I've been having abdominal cramping.
Okay. So just reviewing your intake form based on the anatomy here, it seems like this might have to do with some of the anatomy in your abdomen and pelvis. How would you feel about doing an internal ultrasound?
Okay, let's do it.
Hi, Dominic. How are you doing today?
I'm doing well. How are you?
I'm good. Thanks for asking. Is it okay if we talk about your test results?
Yes.
So we noticed a mass on the ultrasound, and I'd like to send you to a specialist to do some more testing. So somebody from our office will give you a call with an appointment time.
Okay.
Hi, Dominic. This is David calling from the doctor's office. I'm calling to schedule an appointment for you.
Great. Thank you.
And I think one of the other things that it does stress is that sexual orientation and gender identity data can be very sensitive, not only to the person answering the form who may have questions of what are you going to do with this information? How is it going to be stored? Who's going to have access to it? But for the clinicians, it would be, it wouldn't be fair to admit to some discomfort on how to ask the questions, especially when it comes to things like an anatomic inventory, because not everyone who is trans is going to have the same journey to their own gender identity. But not to ask the questions can have such ramifications in the screening realm, and also as we go about our differential diagnosis and approaches to treatment. What I think this nicely shows is that, you know, having the patient answer an intake form privately or at their own time and know that that information is going to be looked at can be a very useful thing for both to help preserve and might I say even, you know, foster a doctor-patient relationship.
Yeah, I really agree with that, that providing patients with the privacy to fill these things out on their own, and providing clinicians with the information they need for clinical problem solving really probably does provide some comfort on both the patient and clinician side and lead to a better relationship and more rapport.
Mm-hmm. And especially when it's not guided, you know, as in this case, by an assumption of what is already going on, that, oh, it's your bladder, or it's definitely your colon because you're a woman, it's clearly IBD. I mean, we still see these sort of characterizations of diseases being gendered, which you and I have spoken about quite a bit, that, you know, diseases don't have genders. Diseases are some things that everyone experiences, and it doesn't respect lines around that.
Yeah, definitely.
Well, I think as we look at the conversation that was had, a big word that comes up is this very important consideration of respect.
So respect is a huge thing for me, and I would want my doctor to be respectful of who I am as a person when they're doing an examination, and to not make assumptions. Also, it's important for me that clinicians be direct with their questions and ask what they want to know. For example, do you have ovaries, or do you have penetrative sex, instead of what is your sex and are you having sex?
And that all of our patients deserve our respect, and it need not be confined to any one category of person, that in order for us to achieve equality in healthcare, and with that the equity in the choices that people have when it comes to their treatment, we need to show a little bit of cultural curiosity and get to know people, not by assuming who they are, but by asking them questions and giving them the opportunity for them to tell us. So, Dr. Alpert, as we go forward, can you review some of the key communication concepts that open the patient-doctor relationship and lead to high-quality care, particularly as it relates to cancer screening?
Absolutely. You know, I think one thing that I really love about this set of videos is that the actor in the video actually does a debrief where they talk about what's really important to them in clinician-patient encounters. And they mention, just like you said, how important respect is for them, and the importance of clinicians asking direct and specific questions.
It's always a good idea to introduce yourself with your name and pronouns, and then ask what the other person's name and pronouns are. If it's in a returning patient, it should be in the chart somewhere where the physician can review.
So for example, are you having sex is a very vague question, because there's lots of types of sex. And what is your gender, or what is your sex, may also be very vague and unclear questions. So asking questions that are much more specific, and then also ensuring that you introduce yourself with your name and pronouns and ask the patient to do the same, so that you can refer to them in a respectful way. And the last thing that the actor in the scenario brings up, or the patient in the scenario brings up, is that oftentimes they've had the experience that clinicians assume that the cause of symptoms or disease are hormone therapy, when that's often not the case.
When it comes to conversations with clinicians, the one thing that always comes up is hormone replacement therapy. Often clinicians assume that testosterone is the cause of my symptoms, when that isn't really the case.
And so really trying to keep that in mind when you're thinking about what's going on, particularly for a transgender person on hormone therapy, and how your biases against hormone therapy might influence your differential diagnosis, I think can be really useful.
Well, thank you, Dr. Alpert, for that very interesting discussion. Let me close out this portion of the program with some SMART goals. SMART meaning smart, specific, measurable, attainable, relevant, and timely. So one of the first things is to create a physical environment that is gender neutral and which will be seen as inclusive of SGM patients and their loved ones and caregivers. To approach and speak to all patients without any assumptions about their own gender and anatomy. And that includes using your pronouns as a way to ask them for theirs. And then addressing cancer screening in particular through the relevant anatomical needs of patients, not based on the presumptions you make about their gender. Please visit the CME Outfitters Oncology Hub to access additional activities on relevant oncology and disparities topics, as well as resources and patient education material. To receive CME CE credit for today's program, complete the post-test and evaluation. You'll be able to download and print your certificate immediately upon completion. Thank you to my good friend, Dr. Ash Alpert, for today's discussion. And thank you to the audience for joining us.